Assalamu alaikum everyone. Bismillahirrahmanirrahim. I welcome you all for joining my class. Let me introduce myself. I am Dr. Mubasshra and I am currently working as a consultant medical specialist. I have arranged this class which is short case pulmonology class, and I hope that this class will be helpful for all of you whichever clinical medicine exam you are appearing in. And I will try my level best that at the end of the class you people will have a good understanding of pulmonology. So let's start. Respiratory system examination is a very important short case in clinical medicine exam. Most of the time, what commands you people get, either you will get the command examine the front of the chest, examine the back of the chest, or examine the chest of the patient. Or even in case of PACES or FCPS, you can get this command that this patient has presented with shortness of breath. Please examine the chest and do the relevant examination. Sometimes they will tell you that this patient has presented with dry cough or productive cough. Please examine the chest and do the relevant examination. And whatever your present command is, I would suggest you people that always start from the back of the chest, because most of the time the finding is in the back of the chest. Because you know that the pulmonology station is also very lengthy examination, just like neurology. And the most important thing is that whatever your command is, if the command is front of chest, the most common relevant of front of chest is back of chest. And if the command is back of chest, the first relevant of back of chest is front of chest. So basically, they just want you that whether you will do the relevant examination, I mean the front of chest as well or the back of chest as well. So this is a lengthy examination, especially if you are appearing in FCPS exam or your local medicine exams, MD exam, because in that exams they will only give you 4 minutes or 5 minutes. However, it is a good thing that PACES candidates gets a lot of time for short case examination. That is, they will get full-fledged 6 minutes, and it is possible to do front of chest, back of chest, as well as all the possible relevant of respiratory system in 6 minutes. So let's start about the scheme of examination. First of all, you will enter the room or enter the cabin. You will greet your examiner. You will say good morning or you will say assalamu alaikum. They will give you the command. After that, you will sanitize your hands. Must remember to sanitize your hands. After that, you will go towards the patient. You will introduce yourself. And during introduction, you will also take the consent. So how you will introduce yourself? You will say, अस्सलाम वालेकुम, मेरा नाम डॉक्टर मुबशरा है, मैंने आपकी छाती का मुआयना करना है, आपको कहीं पे दर्द हुई तो बताइएगा, मैं वहीं पे रुक जाऊंगी. This sentence you will use when you are appearing in FCPS or MD exam. However, if you are appearing in PACES exam in international centers, for example, like in UK, Ireland, you will say, hello, good morning. I have been asked to examine your chest. First of all, you will tell your name. Hello, good morning. I am Dr. Mubashra. I have been asked to examine your chest. Meanwhile, if you feel any discomfort or pain, please let me know. In this way, you will not only complete the introduction, but you will also take the consent of the patient in the form of informed consent. Okay. After that, you will start your examination. One thing more I want to tell here is that most of the time, everyone who is appearing in PCS exam, the examiners ask you to proceed in your local language. So you will do each and everything just like you perform in your local medicine exams. After that, you must check that whether the patient is lying in proper position or not. Most of the time in chest examination, the patient should be lying up in a prone position, like at 45-degree angle. Or if they are sitting, then it's also okay. After that, you will make sure that the patient is properly exposed or not. If it is a male patient, his shirt should be removed ideally, or the patient should be exposed till waist. After that, come towards the foot end of the bed. While going towards the foot end of the bed, you will have a keen look and a good observation of the surroundings. What you will look in the surroundings? You will look for oxygen cylinder. If there is an oxygen cylinder, whether it is working or not, I mean, the patient is using this oxygen. If he is using, either he is using it nasal cannula or face mask. If patient is using the oxygen, you should have checked that at what level the patient is taking oxygen in. For example, you will check whether he is taking in oxygen at 3 liters per minute, 4 liters per minute, whatever the reading on the monitor, I mean the scale, you should check for that. After that, you will look for sputum count. All of these things will give you a clue even before starting the chest examination. That how it can give you the clue. If the patient is using oxygen via nasal prongs, you will get a clue that either it can be a case of interstitial lung disease or it can be a case of chronic obstructive pulmonary disease. If there is a sputum pot, it will give you a clue that this patient might be a case of bronchiectasis or he is having productive cough. I mean, there will be some forced crepitations inside his chest. If there is inhaler, you will look for that what is the color of inhaler. Is it blue inhaler or it is brown inhaler? What color, what clue you will get from these colors? If it is a blue inhaler, it is most probably beta 2 agonist in the form of salbutamol. And if it is a brown inhaler, it has inhaled corticosteroids. This will give you a clue that either this patient is of bronchial asthma or even chronic obstructive pulmonary disease or even bronchiectasis or pulmonary fibrosis as well. He might be taking inhaled corticosteroids. If there is a nebulizer, you will also observe for this. And all these things you need to tell to the examiner in your presentation that yes, I look for these things in my surroundings. You will also look for if there is any spirometer or peak flow meter, which will give you a clue that it might be a case of bronchial asthma. After that, you will come towards the foot end of the bed. Foot end of the bed, you will look for general look of the patient. Is the patient is cachectic, wasted, temporal wasting, general emaciation? What is the body habitus of the patient? Any syndrome-like look, any Marfanite body habitus, Cushingoid appearance, pink puffer, blue blotter, pursed lip breathing, tripod posture, rheumatological evidence that this patient might be a case of systemic sclerosis, rheumatoid arthritis, SLE, dermatomyositis, or even psoriasis. And whether this patient is tachypnic or breathing at a good rate and good color, or whether this patient is using accessory muscles of respiration. All of these things you need to check at the foot end of the bed, and it will not take more than 10 seconds. Okay, and but these things will give you many clues. For example, if the patient is cachectic, he has temporal wasting, overall look is quite emaciated, it will give you a clue that it might be a case of obstructive lung disease in the form of chronic obstructive pulmonary disease, or it might be a case of bronchogenic carcinoma. If he has morphinite body habitus, then you will look for pulmonary fibrosis or any chest deformity in his chest in the form of pectus excavatum. If he is Cushingoid, how it will help you in your findings in the chest. It will give you a clue that this patient might be taking steroids, oral corticosteroids. And what condition it could be? It could be a case of bronchial asthma. It could be a case of interstitial lung disease. If this patient look like pink puffer, he has facial congestion, he has pursed lip breathing, you will get sure, not 100%, but it will give you much confidence at the foot end of the bed that it might be a case of emphysema. You will look for hyperinflated lung fields at the foot end of the bed, or the patient might be blue blotter, his lips will be cyanosed. You will assess yourself that okay, it might be a case of a chronic bronchitis. Again, the same finding, chronic obstructive pulmonary disease, or if it is a case of rheumatology, systemic sclerosis, he has microstomia or beak-like nose. It will give you a clue that okay, what I will find in my chest, in the chest of this patient. It might be pulmonary fibrosis, there will be signs of pulmonary hypertension, or many other signs. If this patient look like rheumatoid arthritis, that is, he has obvious hand deformities in the form of rheumatoid hands, it will give you a clue that there might be bronchiectasis inside, because rheumatoid arthritis and bronchiectasis are quite linked with each other. It might be a case of pulmonary fibrosis, or the patient might have methotrexate induced pneumonitis. So multiple things will come in your mind in the initial 5 to 10 seconds of examination at the foot end of the bed. Likewise, if it is a case of dermatomyositis, he has evidence of heliotrope rash on the on his eyelids, and also you can look for cotton papule even at the foot end of the bed, which you can confirm when you will go towards the right side of the patient. Or there are psoriasis patches visible on his skin at the foot end of the bed. It will give you a clue that I have to focus on the apex of this patient while auscultation. It might be a case of upper lobe lung fibrosis in the form of apical lung fibrosis. And if the patient is tachypnic, he is using accessory muscles of respiration, you will get a clue that okay, he might be in a type 2 respiratory failure. What findings I will assess in the when I will go towards the right side of the patient while doing my general physical examination, starting from the peripheries. So initial 5 to 10 seconds of general look of the patient surroundings will give you many clues. So here your observation should be quite strong. These are some pictures. Okay, first picture on the left hand, this patient is quite emaciated. He has generalized wasting. You will you will have a general look that okay, it might be a case of tuberculosis, or it might be a case of chronic obstructive pulmonary disease, or even lung cancer. Patient might be tachypnic. He will be using accessory muscles of respiration. There might be indrawing of the ribs while inspiration. So multiple clues at the foot end of the bed. Patient has temporal wasting in the second picture, or in the third picture, this patient has pectus excavatum. It might be a Murphy body habitus. And what other things I will look for on auscultation of the especially back of the chest. In the second row, first picture, this female patient, you will get a clue that she might be taking oral corticosteroids. She has Cushingoid appearance. She has round plethoric face with acne marks. I would say try to avoid these terms: moon-like face, buffalo hump, when you are presenting your findings to the examiner, because some examiners do not like this. Instead, you can use this word like a round plethoric face with acne marks or hirsutism, showing that this patient has Cushingoid appearance. Or instead of using the word buffalo hump, you can use the word increased fat pad at the root of the neck. This will give you a clue that this patient might be bronchial asthma. That's why she has been taking oral corticosteroids for a long period of time. Or even it can be a case of interstitial lung disease. Then this patient, he is in tripod posture. Most likely he will be a case of chronic obstructive pulmonary disease. He is using oxygen by nasal cannula, and he has oxygen cylinder lying by his side, and you will look how much oxygen he has been taking in. Then the last picture. So at the foot end of the bed, just by looking at this patient, you might get a clue that this patient has microstomia. He has skin tightening, skin thickening, as well as sclerotectily, Raynaud's phenomena, and puckering of skin around his lips and beak-like nose. So it will be a case of systemic sclerosis. So further, what should I look for in auscultation of the chest? So this foot end examination is very, very important in case of pulmonology. Okay, you have completed the uh, examination at the foot end of the bed in initial 5 to 10 seconds or even 20 seconds. Now come towards the right side of the patient and start his hand examination. First of all, in hand examination, nails are very important. What you will look for in the nails, you will look for clubbing. This clubbing will give you multiple clues. It can guide you that this patient might be a case of interstitial lung disease, bronchiectasis, bronchogenic carcinoma, multiple clues. Just by observation, you will comment on the clubbing, or you will ask the patient to approximate his two fingers just to confirm. No need to use card method. After that, you will look for any evidence of peripheral cyanosis, nicotine staining, yellow nails, or findings of psoriasis nails in the form of nail pitting, onycholysis, and transverse ridges. You can also look for nail fold infarcts, which might be present in a case of rheumatology. After nail examination, you will move towards the hands. What you will do, you will ask the patient to please outstretch his hands for you and spread out the fingers, and please close his eyes. Here you will look for fine tremors. And if fine tremors are present in a case of pulmonology station, what clue you can get? You can get that this patient might be taking salbutamol, I mean beta 2 agonist therapy, and these are the side effect of beta 2 agonist in the form of fine tremors. After that, you will look for flapping tremors, which will give you a clue that this patient will have carbon dioxide retention. He might be in type 2 respiratory failure. Palmar erythema, again, it will give you a clue that it might be a case of rheumatoid arthritis, or even in a respiratory failure, patient can have palmar erythema congestion. Then you will look for wasting of small muscles of hand. This wasting is mostly present in case of pancreas tumor whenever there is involvement of C8T1. After that, you will look for any evidence of oral corticosteroids in the hands. How you will look? You will just comment on skin thinning, that is paper thin skin, bruises, purpura, or ecchymosis. Even there can be presence of sclerodactyly, skin tightening, skin thickening, and Raynaud's phenomena as a part of systemic sclerosis. Or patient might have rheumatoid hands in the form of multiple joint deformities, joint swelling, evidence of synovitis, and ulnar deviation of the hands. And then you will look for hyperpulmonary osteoarthropathy as a part of bronchogenic carcinoma. And how you will examine for this? You will just grasp the hand, I mean the wrist of the patient, and you will ask him, do you feel any pain? In this way, you will check for hypertrophic pulmonary osteoarthropathy. After that, you will look for respiratory rate. Now it is up to you. Some candidates look for respiratory rate when they are at the foot end of the bed, and some people do it while coming towards the right side of the patient. One thing very important here is that FCPS and MD students or residents, basically they cannot pass the short case if they do not comment on the respiratory rate. You will need to count the respiratory rate for 15 seconds and then multiply it with 4, and also comment that whether the patient is breathing at normal rate or he is tachypneic. But PACES candidates do not need to calculate the respiratory rate, either they will get it or they just need to comment that the patient is tachypneic or not. And most of the time, in case of PACES exam, they have printed a paper, and it is there on the wall on, and it has shown the respiratory rate. After that, you will check the pulse of the patient. You will comment on the rate, that whether this patient is has tachycardia, how this tachycardia will, I mean, what it will give you in pulmonology station. If the patient has tachycardia, it might give you a clue that this patient has hypoxia. And because of the hypoxia, the patient has tachycardia just to overcome the hypoxia. Then you will comment on the rhythm, that whether it is regular or irregular. Because in case of chronic obstructive pulmonary disease and respiration, most of the time, depend on that this patient has irregular rhythm, it can give you a clue that he might be a case of exacerbation of COPD. After that, you will check the bounding pulse, water hammer pulse, or collapsing pulse, and it will give you a clue that this patient might have carbon dioxide retention. Then coming towards the arms. In arms, again, you will look for proximal myopathy. This proximal myopathy will give you a clue that this patient might be taking oral corticosteroids. That's why he has developed proximal myopathy. Again, you can look for rheumatoid nodules if there is any evidence of rheumatoid hands, and you can also check for tattoos or needle prick marks. How they will guide you? They might give you the clue that this patient might be a case of lung abscess because of the IV needle prick marks. Then moving towards the face. Before moving toward the eyes, you will have a general look of the face if you haven't looked for quite closely at the foot end of the bed. Here you will confirm your findings in the form of temporal wasting, cushingoid face, any rash present. If there is rash, what is the distribution of the rash? Is it malar rash? For example, there is sparing of nasolabial fold, or it is heliotrope rash that is present on the eyelid of the patient, which might give you a clue that it might be a case of dermatomyositis. And then you will look for plethora, facial congestion, Horner syndrome, that is, there is grouping of eyelids with anophthalmos, deeply seated eyelid, eyes, and meiosis. Because if it is a case of pancreas tumor, there will be Horner syndrome, and the pancreas tumor will be lying on the same side where the eye is infected. And again, the hand findings will give you the clue if there is any wasting of small muscles of hand towards that side. Then you will check for the conjunctival congestion or pallor. After that, you will ask the patient that can you please open your mouth for me, and you will look for any evidence of oral ulcers. It might be present in case of SLE or oral candidiasis. If there is any oral candidiasis present, it will give you a clue that this patient might be taking inhaled corticosteroids. And then you will ask the patient to touch his tongue to the rooftop, and here you can look for central cyanosis. Or if the central cyanosis is too severe, it will be present on the tongue. Just by opening the patient's mouth, you will assess it, and even he will have bluish discoloration of his lips. After face examination, you will come towards the neck of the patient. In the neck, tracheal position is very important. One thing I want to tell you here is that you should check the trachea always when the patient is lying supine, because at that position it will not mislead you. Tracheal position, normally it will be in the center or slight deviation towards the right, but you should check the trachea when the patient is lying supine. You will also check the tracheal tug. You will ask the patient to take deep breath in, and you will see that whether the trachea has touched your finger or not. Then you will assess the cricosternal distance. If it is decreased, it will give you a clue that it might be a case of chronic obstructive pulmonary disease. Trachea will be assessed by single finger method or two finger method or even three finger method. But I feel that single finger method gives you a good clue that where the trachea exactly is. But it is up to you. Whatever method suits you, you can use that. After that, you will look for scars in the neck. Most of the time, the scar in pulmonology in the neck, it will be a tracheostomy scar. However, there can be any scar present, you should comment on it. Parathyroidectomy scar, thymectomy scar, or thyroidectomy scar. After that, you will look for lymph nodes. I would suggest you that you should examine the lymph nodes after completing the back examination, because at this moment it will give you a good clue. Patient position will be appropriate, because once the patient is lying in front of you, it is difficult to examine the lymph nodes, and sometimes the Pakistani examiners also mind that how you are looking for lymph nodes. This is not the method to check for lymph nodes. So ideally, the lymph nodes should be checked once you have completed the examination of back of chest. Just before you ask the patient to lie down, you will ask him that now I am going to check the glands of your neck, and in that way you can check the glands, and after that you will ask the patient to lie down. But it's up to you, whatever scheme you have made. If your exam is near, there is no need to change your scheme. However, if there is time, you should make up your scheme so that it will become a second nature to you, and you don't need to think about the next step of examination in your exam. After that, you will look for JVP. Now it is up to you. You check the JVP here, or you will check the JVP when you will examine the front of the chest. Now coming towards the very important step of pulmonology examination, that is the back of chest, because this will give you the diagnosis. In the back of the chest, what you will say to the patient that can you please move your chest towards me, I mean the back towards me, and can you please make a posture that your right hand is touching your left shoulder and your left hand towards the right shoulder in a Caesar like position. In this way, the scapula will be moved apart and you can examine the chest quite in a good manner. After that, a good inspection of back of chest is very important. What you will look, chest deformity, although the chest deformity is more important when you are examining the front of chest, but still here the inspection will guide you that whether there is any bulging, elevation or depression on any side of the chest. It will give you a clue. If there is bulging or elevation in any side of the chest, it will give you a clue that it might be pleural effusion lying here, or if there is any depression over here, then you will get a clue that it might be a case of collapse, or it might be a case of pneumonectomy or lobectomy. However, for that there should be presence of scar mark, and the scar marks important in case of chest examination. The most common scar is lateral thoracotomy scar. How you will comment on the lateral thoracotomy scar, that if this is there is a lateral thoracotomy scar present on the right side or left side of the chest extending posterolaterally. Some candidates only comment on the lateral thoracotomy scar and they just totally ignore the small drain scars which are present underneath. So you should also comment on the drain scars if they are present. And not only the lateral thoracotomy scar is important in case of back of chest examination, there can be a case of, for example, wets. This wets procedure is very common, and there are just small scar marks present, and they are mostly present on the upper chest. So if there is any scar mark, you will comment on it. However, one very important thing here is that whatever clinical medicine exam you are appearing in, never try to invent any finding. If you miss any subtle finding, no problem. However, if you create any finding, it will give a very bad impression on the examiner. After completing your inspection, now you will come towards the palpation. In case of palpation, you will just check for chest expansion by hands. If you are examining the back of chest here, you will check the chest expansion in the three parts. First, you will move your fingers towards, you will put your fingers high up on the apex of the lung, and your thumb will be quite wide apart from the skin. They should not be touching the skin of the back. And then you will check the chest expansion. Then you will check the chest expansion in the middle of the chest, and after that and at the lung bases. And you should have a keen observation that where the chest expansion is reduced, because wherever the chest expansion is reduced, the finding will be lying over there. For the FCPS candidates and the MD candidates, they will need to measure the chest expansion as well with the measuring tape, but no need in case of PACES exam. After that, not only moving towards the percussion, the FCPS candidates also need to do the vocal parameters. Although it is obsolete now, but still some examiners mind it that you have missed this part. After that, come towards the percussion. Percussion has high yield. It will give you a clue that whether it is, if it is resonant, okay, what findings will be there. If it is dull, then there will be narrowing of your differentials. And wherever the percussion is dull, you will need to correlate it, that whether the chest expansion was also reduced over here or whatever. After that, moving towards the auscultation. In the auscultation, you will comment on that whether there is normal vesicular breathing, bronchial breath, vesicular breathing with prolonged expiration, any expiratory V's, crepitations. If there are crepitations, either they are fine crepitations or coarse crepitations, and also comment on the vocal resonance. Normal vesicular breath. What is a normal vesicular breath? That is expiration, inspiration is longer than expiration without any gap. However, bronchial breath, it is just like when you put your stethoscope on your trachea, the same finding you will get on the back of the chest, that is inspiration and expirations are equal with a gap. And prolonged expiration, it will give you a clue that this patient might be having chronic obstructive pulmonary disease. These, it can be present in case of bronchial asthma as well as chronic obstructive pulmonary disease. And crepitations, if there are fine crepitations, they will give you a clue that this patient might be a case of idiopathic pulmonary fibrosis or interstitial lung disease, pulmonary fibrosis, or pulmonary edema, or even resolving stage of pneumonia. And if there are coarse crepitations present, it will give you a clue that patient might be a case of bronchiectasis. And vocal resonance, it will be increased if there is bronchial breath, otherwise it will be decreased if it is a case of pleural effusion and multiple other causes as well. We will discuss it one by one. After completing the back of the chest, you will assess the lymph nodes and sacral edema. After that, you will not disturb the patient again and again. You will just ask him, you can lie down now. And no need to again ask him to sit up for you to check for sacral edema or lymph nodes. Just you complete all the steps in the back of the chest and move towards the next step of your examination, that is the front of chest. Front of chest will give you multiple clues in the form of radiation marks. For example, if it is a case of bronchogenic carcinoma and he has undergone chemotherapy or radiotherapy, then you should look for these radiation marks. Scar marks in the form of, for example, the same scar marks like parathyroidectomy scar or thymectomy scar or thyroidectomy scar, you will look here. After that, you will check for apex beat, that whether it is displaced or not. Left parasternal heave, loud P2, palpable P2, and JVP. These four things which are written in the end, these 4 points, they will give you a clue that this patient has pulmonary hypertension or not. For example, the signs of pulmonary hypertension are palpable P2, loud P2. You will not say this word loud P2. Instead, you will say loud pulmonary component of second heart sound. Left parasternal heave might be present if it is a case of pulmonary hypertension, and venous pressures will be elevated if there is pulmonary hypertension present. And one thing more, in the front of chest, you will not complete all the steps, that is palpation, percussion, auscultation. If you feel that you are short of time, you can just skip a percussion, you can just auscultate all the lung fields. Moving towards, starting from the, apex, because apex is very important in front of chest examination. You will get all the clues whenever the patient is lying in supine position. You will look for apex auscultation, and after that move towards the lateral side. And when you are examining the back of the chest, never forget the lateral lung fields, because sometimes the findings are there. Whenever you are doing the lateral examination, you should percuss on the lateral sides as well as auscultate there and check for vocal resonance as well. After that, you will end your examination by looking for pitting pedal edema, because this pitting pedal edema will give you a clue that this patient might be having pulmonary hypertension or cor pulmonale, that is right heart failure secondary to pulmonary cause. And just after completing your examination and you are moving towards the examiner for viva, you should say this sentence, that in order to complete my examination, I would like to do pulse oximetry, bedside spirometry, examine the sputum pot if there is any, check the observation chart, and look for the chest x-ray. And then you will start the presentation. And in presentation, always tell your positive findings first in a sequenced way, and then important negatives. And after that, you will tell the examiner your provisional diagnosis and list of differential diagnosis. So what diagnosis you might get in a case of pulmonology system? The system might be, the case might be chronic obstructive pulmonary disease or asthma, that is obstructive lung disease. What findings might be present in a case of COPD patient? The patient will be cachectic, he will have emaciated look, he will have facial congestion, plethora, barrel shaped chest. But I would say that if you are appearing in FCPS exam, do not comment on that the patient has barrel shaped chest, because there will be again a war between you and the examiner. They will say, how you can say that this is a barrel shaped chest? Have you examined the barrel shaped chest? Okay, what is a barrel shaped chest? You will tell him that AP diameter, transverse diameter, but they will say, have you examined for it? So there, the examination of basically barrel shaped chest itself will take two persons to examine. You alone cannot examine that. That is a separate debate. But if you are appearing in paces, you can comment that yes, it is a barrel shaped chest, or it might be a barrel shaped chest. Then tripod position. Tripod position, if it is a case of emphysema, pink puffer, blue blotter, patient is tachypneic or using accessory muscles of respiration, peripheral cyanosis, central cyanosis, nicotine staining, fine tremors, flapping tremors, bounding pulse, regular pulse or irregular pulse, conjunctival congestion, oral candidiasis. And most of the time, the trachea is central or slightly deviated towards the right side. Tracheal tug might be present, and there will be reduced cricosternal distance. Chest expansion might be reduced. Breath sounds are mostly reduced. Vesicular breathing with prolonged expiration, expiratory wheeze can be there, and if the patient has presented with exacerbation of COPD or asthma, you can get coarse inspiratory crepitations. Percussion note is resonant, and signs of pulmonary hypertension can be there in the form of raised venous pressures, palpable P2, and loud pulmonary component of second heart sound, and left parasternal heave and pitting pedal edema. So, among these findings, whatever your positive findings are, you have to tell positive findings in a sequenced way. In such a way, your presentation should be slick and fluent so that the examiner will also not get bored. Instead, he will enjoy that this candidate is presenting in such a good style. So, your presentation should be very nice. And in presentation, what I would suggest you that start your presentation like this. You will say, first you will go towards the examiner, you will say them that, well, in order to complete my examination, I would like to perform the bedside spirometry, pulse oximetry, examine the observation chart, look for the sputum pot, or look for the chest x-ray. Okay, then they will say, tell me your positive findings. It is a case of COPD. How you will present? You will present in this manner. Well, I have examined this patient. He is lying in bed with a respiratory rate of this, and he remained cooperative throughout my examination. One thing I want to tell here regarding my experience when I was preparing for my exam, many candidates give their feedback. For example, one of the examiners said when the student was presenting to him that this patient was comfortable throughout my examination, he was lying comfortably in bed. The examiner didn't ask him to move forward. He just stopped him there. That is how you think that this patient is comfortable. If he is comfortable, why is he here in the hospital or in the exam setting? So I would say avoid this word comfortable. Instead, just cram this sentence that, well, I have examined this patient and he remained cooperative throughout my examination. He is tachypnic with a respiratory rate of this. Or if you haven't checked the respiratory rate, you can just comment that patient is breathing at a high respiratory rate, or patient is tachypnic and dyspneic. Then you will tell your positive findings first, whatever positive findings in a sequence way. For example, if you have appeared in a FCPS exam, there you need to complete the back of chest, front of chest, and then you will come toward the periphery examination, that is examination of hands and arms and all that. However, in case of PACES, you will start from the hands and then move towards the main targeted examination of chest. So always tell your findings according to the sequence of examination that you performed. For example, you have started examination from hands. You will tell the positive findings of hand first, then arms, then eyes, face, and then you will come towards the chest findings. And whatever important findings, positive findings you will tell, always tell the important negatives. What are the important negatives in case of chest examination? The important negatives are always signs of pulmonary hypertension and peripheral edema. So always comment on them. After that, when you are telling, say it in this manner that according to my clinical examination, the most probable diagnosis is this. Instead of just telling that this patient has chronic obstructive pulmonary disease, no, you will say that according to the clinical examination, most probably this patient has this whatever your provisional diagnosis, and then you will give them a set of differential diagnoses. For example, if it is a case of chronic obstructive pulmonary disease, what is the most important differential here? Obviously, asthma. What asthma? Chronic persistent asthma, most probably. And you will not jump towards that, yes, this patient has chronic obstructive pulmonary disease. Instead, just tell them, I mean, an open diagnosis. Like you will say this patient has obstructive lung disease, most probably chronic obstructive pulmonary disease. And my differential is chronic persistent asthma. And always try to give a full unifying diagnosis that if this patient has signs of pulmonary hypertension or signs of right heart failure, you will include that in your provisional diagnosis. After that, moving towards the next important case, which most of the candidates get in their short case of pulmonology, that is interstitial lung disease. Previously, it was known as interstitial lung disease, but now the new terminology is diffuse parenchymal lung disease. So always try to use this term instead of ILD, and avoid using abbreviations in the exam, that is COPD, ILD. Instead use the full term. And this diffuse parenchymal lung disease is a more preferable term as compared to interstitial lung disease. Pulmonary fibrosis also come under this heading. So what positive findings you can get in case of diffuse parenchymal lung disease? There will be oxygen cylinder. Patient might be taking oxygen by nasal prongs. Patient will be tachypnic. There might be evidence of rheumatology like rheumatoid hands in the form of rheumatoid arthritis or systemic sclerosis, sclerodactyly, Raynaud's phenomena, tightening of skin, or SLE, Meller rash, heliotrope rash if it is a case of dermatomyositis, and beak nose and microstomia if it is a case of systemic sclerosis. Gray skin pigmentation. Okay, some patients might get pulmonary fibrosis because of use of amiodarone. So always comment on it that whether if there is any gray skin pigmentation present, you will look for that. After that, conjunctival congestion, clubbing, it is very important in case of diffuse parenchymal lung disease, and peripheral and central cyanosis. Evidence of steroid use, because interstitial lung disease patients might be on steroid therapy for a long period of time. They will have paper thin skin, purpura, bruises, ecchymosis, and proximal myopathy, Cushingoid appearance. In case of interstitial lung disease or diffuse parenchymal lung disease, the trachea is most of the time central. There is reduced chest expansion, percussion note will be resonant, and fine and inspiratory crepitations which do not change their character on coughing, and signs of pulmonary hypertension. So always try to give a unifying diagnosis to the patient. For example, he is a case of diffuse parenchymal lung disease secondary to rheumatoid arthritis. You will comment, and also he has signs of pulmonary hypertension. When you are presenting your positive findings or all important negative findings, and then you are telling the most probable diagnosis, you will tell the diagnosis in this manner that this patient might be a case of interstitial lung disease, diffuse parenchymal lung disease with secondary to rheumatoid arthritis, and he has signs of pulmonary hypertension as evidenced by loud pulmonary component of second heart sound, left parasternal heave, and pitting pedal edema, as well as raised venous pressures. So always give a full-fledged unifying diagnosis. And also, your presentation should be so slick and fluent so that the examiner also enjoy, and he does not need to think that whether I should pass this candidate or not. Instead, he should be sure that this candidate is a candidate who should pass his exam. How your presentation can be slick. Instead of telling the examiner on inspection this, on percussion this, on auscultation this, instead you can present your findings in this manner, that on examination of the chest, in the lower part of the chest, on both sides there is reduced chest expansion, percussion note is resonant. On auscultation there is fine and inspiratory crepitations which do not change their character on coughing, and vocal resonance is equal, normal, and comparable on both sides. So in this manner you will just tell your positive findings, and after that tell your any important negative if it is there. Then moving towards the very important case, bronchiectasis. What findings you will get in bronchiectasis? Here I have written only the important findings, otherwise there can be many findings present. For example, clubbing, yellow nails, fine tremors, even there can be evidence of rheumatoid hands, because rheumatoid arthritis and bronchiectasis, they have very strong association. Whatever your positive findings, you will comment on it. And when you are presenting your findings in case of bronchiectasis, you will say on examination of chest, on the in the lower part of the chest on both sides there is reduced chest expansion, percussion note is resonant, and there are coarse inspiratory crepitations which change their character on coughing, and vocal resonance is equal, normal, and comparable on both sides. Signs of pulmonary hypertension, if they are present, and pedal edema, if there is present, you can comment on it and then give your list of differential diagnoses. Pleural effusion, very important short case. Because what happens in pulmonology, there are only few cases which you can get. Either it is chronic obstructive pulmonary disease, asthma, interstitial lung disease, diffuse parenchymal lung disease, pulmonary fibrosis, bronchiectasis, pleural effusion, or bronchogenic carcinoma, collapse, pneumonectomy, or lobectomy. Not more than these cases will come. So it is not a difficult short case. Just you need to practice it in your examination, as well as practice it while presenting to the patient, to the examiner. So what findings you can get in case of pleural effusion? If the findings we talk about in the chest, here the trachea will be deviated. If it is massive pleural effusion, trachea will be deviated towards the opposite side. For example, pleural effusion is present in the right side of the chest, trachea will be shifted towards the left side. There will be bulging and elevation of the chest. There can be reduced chest expansion towards the side of pleural effusion. Percussion note will be dull. Some candidates also use this word stony dull. However, some examiners say, okay, what is the difference between stony dull percussion note and dull percussion note? Then you can be blank. So dull percussion note only will justify it that it is a case of pleural effusion, and reduce breath sounds and reduce vocal resonance on the side of pleural effusion. So how you will present if it is a case of pleural effusion? You will say in the, for example, it is a case of right-sided pleural effusion. You will say, after telling your all positive findings in the periphery, you will say in the right lower part of the chest, there is reduced chest expansion, percussion note is dull, there is reduced breath sound as well as reduced vocal resonance. However, if you get a patch of bronchial breathe, which is most of the time present in case of pleural effusion, just where the pleural effusion ends, just above that border, there can be bronchial breathe and increased vocal resonance. And the underlying cause might be that there is lung collapse over the pleural effusion. So you can comment on it if it is present, that is bronchial breathe and increased vocal resonance just above the right lower part of the chest. And after that you will tell your findings in the left part of the chest, that there is normal vesicular breathing with no added sound, and percussion root is resonant, and vocal resonance is also normal, and there are no added sounds present over there. So in this way you will present your findings of pleural effusion. Then very important case, pneumonectomy, which is very important in case of PACES exam. In case of pneumonectomy, what findings you will get on examination of the back of the chest? There will be lateral thoracotomy scar, which will be extended posterolaterally, along with small drain scars, two or three, whatever scars you will get, you will comment on it. And the chest will be depressed and flattened towards the side of pneumonectomy. And there will be depression towards the whole side. For example, it is a case of left-sided pneumonectomy. Whole of the left side will be depressed and flattened, and trachea will be shifted towards the side of pneumonectomy. This will give you a clue even before examining the back of the chest. What findings you will get in a case of pneumonectomy? There will be reduced chest expansion, dull percussion note, reduced breath sounds, and decreased vocal resonance. However, because of the tracheal stump, that is the on the side of the pneumonectomy, where, for example, it is on the left side, just on the upper part of the chest, you can get a patch of bronchial breath with increased vocal resonance, and the underlying cause is because of the leftover tracheal stump. That's why you can get this finding, and in case if you get this finding, you should comment on it. After that, you will also comment on the findings on the opposite side of the pneumonectomy, because most of the time what causes this is basically a very extensive thing, I mean very extensive topics. Interstitial lung disease, diffuse parenchymal lung disease, pleural effusion, all these things need a whole one class. Here I just need you to just give you a bird eye review, that how you can present these cases in your short cases. However, I will try to do these topic wise as well whenever I will get time, and I will share these in the group as well as on YouTube, so that you can learn this whenever you need. Because there are multiple causes of pneumonectomy. How you can remember? Because multiple causes and multiple things are difficult to memorize in the exam. Just remember a mnemonic, TBM. How you can remember? T stands for tuberculosis, B stands for bronchogenic carcinoma, and M stands for malignancy, and sorry, B stands for bronchiectasis. So tuberculosis, bronchiectasis, and bronchogenic carcinoma. These are the main causes of not only pneumonectomy but also lobectomy. Because lobectomy is basically performed in case if it is localized bronchiectasis. So just you remember this mnemonic TBM, you can remember that what are the causes of pneumonectomy or lobectomy. And in case, if it is a case of bronchiectasis and patient has undergone pneumonectomy, the findings can be present on the opposite side of the pneumonectomy. That is, it is a left-sided pneumonectomy, left-sided thoracotomy scar is present. There can be possibility that on the right side of the chest, patient has coarse inspiratory crepitations present on the lung base. So it will give you a clue that this patient has undergone pneumonectomy secondary to bronchiectasis. So the examiners will be impressed by your finding that this candidate is so much nice that he has not only concluded that this case is pneumonectomy, but instead he has concluded the cause of pneumonectomy in his 4, 5, or 6 minutes of examination. So always the findings on the opposite side of the pneumonectomy and lobectomy can give you the cause or etiology of underlying pneumonectomy or lobectomy. Okay, now coming towards the lower lobectomy. What findings you can get in case of lower lobectomy? Again, the same lateral thoracotomy scar with drain scars. Trachea will be central. So remember, it is trachea is central, and there is a lateral thoracotomy scar on the back of the chest. It will give you a clue that it might be a case of lower lobectomy. Again, you can find on inspection that his upper chest is normal, but the lower chest feels like depressed or flattened. So again, it will give you a clue that it might be a case of lower lobectomy. But for these findings, you need to have a very keen observation and keep on examining these patients of scar patients, pneumonectomy and lobectomy. And when you correlate them, you can easily get the diagnosis, because this might you will see that no, it will be a very difficult case. Otherwise, once you see these patients, you will get that okay, these are very easy to diagnose. So what will happen? Trachea is central, chest is depressed and flattened only in the lower part of the chest. Only in the lower part of the chest you will get reduced chest expansion, dull percussion note, and decreased breath sounds, as well as decreased vocal resonance. And all the normal findings on the upper part of the chest, on the side of the lobectomy, and even on the opposite side of lobectomy, or in case if this patient has undergone lobectomy because of bronchiectasis, there might be findings on the opposite side of the chest. However, if it is localized bronchiectasis and patient has undergone only lower lobectomy because of localized bronchiectasis, then the opposite side might be normal. But whatever findings are present on the opposite side of the chest, you should comment on them. And then coming towards the upper lobectomy. Upper lobectomy, trachea will be shifted towards the side of lobectomy. Now see, trachea is shifted towards the side of lobectomy. You will see that okay, it might be a case of pneumonectomy or upper lobectomy, but the chest will be depressed and flattened towards the side of lobectomy. Lower chest might be normal. Chest expansion will be normal in the lower part of the chest if it is upper lobectomy. And the chest expansion will be reduced only in the upper part of the chest. Percussion note is dull, bronchial breathe, and decreased vocal resonance. Bronchial breathe or increased vocal resonance, basically these two things go side by side. Bronchial breathe might be there because of the shift of trachea towards that side, and even the vocal resonance can be increased if it is bronchial breathe present over there. But it is not always the case. It just depends upon the tracheal shift, that if the trachea is deviated towards the side of lobectomy, then you can get bronchial breathe and increase vocal resonance over that area. Okay, basically I have just cut short all of these cases in case of pulmonology. Otherwise these are very extensive topics, and they need a whole one class, I mean each topic. So basically I just wanted to tell you all the positive all the important cases in case of pulmonology, their scheme of examination, and how you should present your case in case of chest examination, because this is a very important short case, and all the PCS candidates will get a short case of chest examination. And most of the time FCPS candidates can get, or might be a possibility that they will not get But whenever it is there, it is not a difficult case because only 4, 5, or 6 important findings will be there, and most of the time the findings are there whenever you examine the back of the chest. So, thank you so much for joining my class. If there are any questions, please let me know. You can unmute yourself or you can write in the chat box. So, I think there is no question. Although I want that you people ask the question because in this way we can interact in a better way, and I can also assess that whether you have learned anything from the class or not. In case if there is any question, you can ask even in the group, and I will try to answer there as well. So I think there is no question. So thank you so much for joining this class. Stay blessed. All the best. Allah Hafiz.